Well, I'm going to start off by giving you a background about why we're doing this work, and then I'm going to give you an overview of our approach we're using to designing interventions. And by interventions, I mean healthcare practice, a strategy, a treatment, and then I'll talk a little bit about how you might want to get involved. So for the background, what we've been focused on in this study is persons living with cognitive impairment. And by cognitive impairment, I mean it can range from trouble thinking, remembering, concentrating, and or making decisions, all the way to having an actual diagnosis of Alzheimer's disease. And people with these conditions are at high risk for hospital admission and readmission compared to those without cognitive impairment. And there's a big risk of functional decline that they can experience while they're in the hospital, and also 1 month after discharge. And by functional decline, I mean physical and cognitive functioning, things like doing everyday activities like getting dressed, getting around independently, going to the toilet on your own, things that we take for granted every day. And there's a lot of research now that shows that if people don't regain what they might have lost in hospital over that 1 month post-discharge period, they're unlikely to ever regain those functioning abilities. So we use the term cumulative functional declines, which refer to the physical and the mental ability to do their usual activities. And so we have a service called Transitional Care, and this is a health service that supports self-care and recovery after a person goes home from the hospital. And it starts in the hospital. And by self-care, I mean being able to take care of yourself, knowing the things that you need to do on your own to get better, to return to your usual activities and your functioning. And transitional care starts in the hospital. And so before people leave the hospital, they need to receive the information on how to get back to their usual level of functioning. And we do have transitional care research, but most of what we know from transitional care research has not focused on functioning or how older people with cognitive impairment can get back to how they were functioning before they went into the hospital. Much of what we know about transitional care is from research done in urban areas with people who do not have cognitive impairment. And so this really limits the applicability of transitional care to people with cognitive impairment who live in rural communities. So we know from that we need to develop interventions or strategies as part of transitional care that support a person's functioning after hospital discharge for a medical condition, and supports families and other care partners' ability to promote patient functioning, and will work in rural communities. Now I'm going to talk about how we are developing these interventions for transitional care. And so we're using a participatory approach, and the approach has 3 features. The first one I'm going to talk about now is on developing the team. And so we've developed a team of community representatives who bring their knowledge of the lived experience, so people living with dementia and their family members. The team also consists of clinical leaders who bring their expertise of rural healthcare. And this includes administrators, various clinicians who are part of our team, hospital administrators, community care workers. And we also, in our team, have researchers, and these researchers have complementary areas of expertise such as rural health, expertise in aging, expertise in intervention design, and transitional care. And in this community participatory approach to intervention design, we involve all members at the different phases of intervention design. And so now I'm going to talk about the second feature, which involves developing the interventions. And so the first part of developing an intervention is having a really good understanding, a clear understanding of the problem. And our understanding of the problem came through our prior research, our review of the literature, and discussions with healthcare professionals across Canada, and our team of clinical leaders and patient and family representatives. And we learned that older people living with cognitive impairment are often admitted through the emergency department. And I probably don't need to tell you what a stressful environment that is, both mentally and physically. I know when myself or family members have been in the emergency department or emergency room, when they come home, they're really exhausted, you don't sleep well, there's a lot of noise. So you can just imagine what it must be like for somebody living with a cognitive impairment. And then once they get into hospital, they don't sleep well. Their participation in their activities of daily living, particularly getting dressed, patients are usually in gowns, is restricted. And they're very sedentary in hospital and after discharge, and they're tired when they get home. So we can see that this population will experience problems in their physical and cognitive functioning. And also when they get home, sometimes they're so tired that they're just even more sedentary when they get home. This phase also involves us asking, okay, so what's modifiable? What can we change about this problem? And so we know that we can change, we can give people education on what to do after discharge. And knowing the problem is very important because it helps us to design the interventions. So if somebody has poor sleep, we know we're going to need an intervention that addresses sleep, because many people who've been in the hospital, even for a few days, they go home and they no longer are on their regular sleep schedule. And so they might have a sleep problem. So we need interventions that address sleep. If they've been on bed rest or had very limited physical activity, what happens in our body, we have detectors that know when we're lying down and getting up. When we get up, these detectors make sure that our body pumps blood to our heads. Sometimes these detectors don't work so well when we spent a lot of time lying down. So when we get up, we don't get enough blood going to our heads, and we experience what we call in research orthostatic intolerance. And so what that really means is the inability to handle or tolerate being in an upright position. And so what people tend to do when they experience this is they lie back down, which kind of just makes the problem worse, because our detectors stay very, very sluggish. And so because of that, we know we need interventions to address orthostatic intolerance. We need interventions to address walking, to help people get back to walking and be safe while they're walking. And because of the restrictions in performing activities of daily living, we need interventions to address self-care, like how to get back to doing your usual activities. People also, when they come home from the hospital, they're very, very tired, many of them, and they might have trouble thinking clearly, which might even be worse after a hospital stay. So they might have trouble communicating. And so we need interventions to address communication, particularly for family members who may not fully understand why there's such a big change in their relative. And we know because of the sensory disorientation with being in the hospital, you may not have a clock, you're not going outside, getting that natural sunlight. So we need interventions that promote orientation. So what we did is we reviewed the literature and we pulled out information on evidence and on the evidence for these interventions. And we also pulled out information on what is the content of these interventions, what did they involve. And so now I'm going to give you a little bit of a picture of what we did and how we mapped everything out onto an Excel file, actually. And so we looked at what is part of the problem here in the left-hand column. And so we saw through we know through the literature that bed rest leads to changes in the cardiovascular system, those detectors that I told you about earlier, and changes in our muscles. And so we then designed an intervention component. So the first one is being upright. We know that the best way to help get back to our usual activities and be able to tolerate being up is to actually be up. And so our recommendations for this part of the intervention is to get up slowly, because people aren't used to, after they come home from the hospital, they're sometimes not used to getting up. And so we want them to get up slowly so that they don't feel too dizzy. The second recommendation is to sit on the edge of the bed for up to 3 minutes so that their body gets used to being up. And then our last recommendation for that one is to gradually start to increase being up to at least 3.5 hours a day as the person can tolerate it. The second one of the component of the intervention is trying to stimulate blood flow by activating the muscles in our legs. So we found through the literature that we actually found a study that had tested in the laboratory rocking in a rocking chair, and that was found to improve blood flow. So that's kind of what we did by reviewing the literature. And this is what we used for the researchers. And this is what we took that same information and we put it in a table for healthcare providers so that they could understand what the intervention is about. And we developed a written description for each intervention. And here's the example of the orthostatic tolerance intervention that I went through with you in the last slide. And for healthcare providers, of course, this is very, very detailed. So I've provided here the structure of the kind of information that we're providing for healthcare providers. We also package this information into pictures with written descriptions for patients and families to help them understand and remember the recommendations, which I'm going to show you now. And I'm going to use the same intervention, the one for orthostatic tolerance, and give you an example of what it looks like for patients, families, and their other care partners to understand. So you'll see here the first picture that patients and families look at is that too much rest can make you feel dizzy and weak. And then the next one is before standing, get up slowly and sit on the edge of the bed or the couch for up to 3 minutes. The next one is do 3-foot exercises 2 times a day. And so you'll see there it has circle feet, lift your knees, and lift your heels. And these are designed so that people at home can look at the pictures, and it serves as a reminder of what they need to do, and they can review it on their own, and they could ask their healthcare provider questions based on it. And here's another one: be up for at least 3.5 hours throughout the day. And it doesn't mean they have to be up for 3.5 hours all at one time, but 3.5 hours altogether throughout the day. And here's the last one that I told you about earlier: rock in a rocking chair, if you have one, if available. And we brought all these pictograms and intervention materials to people whose lives have been affected by cognitive impairment, to get their perspectives. And you're going to learn about that in the next presentation by Professor McLean. The next part, the last part of our approach to developing interventions to promote older people's functioning is evaluating the acceptability of each intervention to people who are going to use them. And the reason why we do this is, if an intervention is not acceptable to us, are we going to do it? It's highly unlikely, right? If it's too difficult to do, if it's too burdensome, it takes too much, it's unlikely that that will do it. So it's very important for us, before we go full-fledged with this this intervention program, is that we gather the perspectives of patients, families, and healthcare providers who are going to ultimately use the intervention. And we also did a mock interview of this evaluation process with our community representatives, so that we know how to engage members of the community. And we incorporated their feedback as well. And so this slide here, it speaks to how we're engaging patients and their care partners and healthcare professionals as research participants to gain their perspectives on whether or not each intervention is acceptable to them. So in terms of acceptability, we're looking at gathering, tell us about, do you think the intervention will be helpful to you? How easy do you think it will be to use? How relevant is it to your situation? And we're also looking at what do you think are some barriers to using it, or some facilitators? Do you have any suggestions for improving and adapting the intervention so that you can use it at home, or you can use it with the people you're working with? And so that's where we're at right now. Actually, we're still recruiting for the study. We're still working on it. And as you can imagine, recruiting people who are in the hospital and just about to go home, or just got home from the hospital, can be very, very difficult. And so if you're interested in getting involved, we'd love to hear from you. We really believe it's so important to hear the voices of people who will be using the interventions to help us make them as good as we can and as usable as they can. And I put the flyer up here to let you know about our recruitment flyer, to indicate that we're looking for patients and their family members or care partners. And we're also looking for healthcare professionals to participate in our study. And on that note, I'm going to end my presentation, and I believe Gwen is going to be introducing our next speaker.